Mr. Chairman, and I'd like to thank the organizing committee for the kind invitation to give this talk. I'm going to be speaking on the role of CRRT in sepsis and what are the controversies. And as mentioned by the previous speakers, that the host response to septicemia, it's a combination of opposing pro-inflammatory as well as anti-inflammatory reactions. And in the pro-inflammatory response, you will see that there was actually a huge storm of cytokine release and the increase in inflammatory mediators. And this is essentially the pathophysiology in which there was thought that CRRT could intervene in patients with septicemia and provide some favorable outcomes. And acute kidney injury, it's a common occurrence in patients with septic shock. And as mentioned earlier, the pathophysiology involves the formation of microvascular thrombosis, as well as decreased tissue hyperperfusion and oxygenation, and resulting in acute kidney injury, which forms part of the multi-organ failure phenotype. And it is not unfamiliar to this audience that acute kidney injury has a significant impact on morbidity, in-hospital mortality, as well as increased healthcare resource utilization and healthcare cost. In the next 20 minutes or so, I would discuss the role of CRRT in the treatment of patients with sepsis and established acute kidney injury. And because of the theoretical capability of CRRT in removing inflammatory mediators, whether it has any role to play in the form of a preemptive form of therapy in patients with septicemia. So let's answer the first question. In patients with sepsis and established AKI, is CRRT really the best modality? And this is one of the biggest randomized controlled trial, and it's performed by the hemodiaphy study group from France. And basically, they looked at patients who are critically ill, and they randomized them to receive either intermittent hemodialysis or CVV-HDF. This trial was actually carried out in the late 90s as well as in the early 2000s. And what happened, if you notice that predominantly the main reason, the predominant reason for these patients developing AKI is that of medical, and predominantly about 2/3 of them are in septic shock. Before I actually present the results of this trial, I just want to highlight that there was actually a significant proportion of patients who was unable to actually tolerate CVV-HDF and actually switch modality to intermittent hemodialysis. And this actually highlights the problem with this study. If everyone is involved in the care of critically ill patients, you would notice that we actually have a lot more problems in terms of hemodynamic instability with patients on intermittent hemodialysis, and we would actually expect the reverse to be true. But in this case, in this study, most of the patients actually switched treatment from CVV-HDF to intermittent hemodialysis, suggesting that we are dealing with a group of patients who is actually at the better end of stability rather than a very hemodynamically unstable patient. And in this study, what they have shown, with the primary outcome of mortality at 60 days after randomization, there's actually no difference in the group who received intermittent hemodialysis compared to the group who received CVV-HDF. In fact, if you looked at all the parameters that were analyzed, other than a higher incidence of hypothermia in the patients who received CVV-HDF group, the adverse events rates, including hypotension, were actually similar between the two groups. And the authors thereby actually concluded that in patients with acute kidney injury who is critically ill, could be treated with intermittent hemodialysis. And I like to caution on that, because that is really not the kind of experience that we have when we are dealing with critically ill patients. In fact, many of my colleagues will be very hesitant to start a patient on intermittent hemodialysis simply because of the instability for extracorporeal therapies. And so be that as it may, Dr. Bellamore from Australia led a meta-analysis that looks at the difference in modality. And I want to highlight there were some of the studies that were included in this meta-analysis. And if you notice, the numbers that were included in many of the studies are actually very, very small, and they're probably underpowered. And while the study population appears to involve critically ill patients, there were actually quite a heterogeneous group in that there were some that had basically underlying, there were two studies by Dr. Mehta and Dr. Alene that actually included patients with underlying CKD. And while intermittent hemodialysis was the comparator in all these studies, the CRRT modality that was used in all the studies were very, very different. Some of them actually considered, actually compared intermittent hemodialysis with CAVHD, which is probably a modality that we do not actually practice in this day and age. So this is a very heterogeneous group of patients that was included in the meta-analysis. And with that in mind, the meta-analysis actually demonstrated that there was actually no difference between CRRT or intermittent hemodialysis in terms of the outcomes of patients who are critically ill. However, I would like to submit to you that in exactly the same journal, at the same publication, there was a very nice editorial by Dr. Van Bissen as well as Dr. Robert Van Holder, who actually sort of put some perspective in the modality that's being used. In fact, what they suggested was that it's not the difference between intermittent hemodialysis or CRRT. The best modality for the patient is probably the best available modality in the most appropriate patient with a physician who's managing, who has the appropriate training. And it's not a one-size-fits-all. So in centers where CRRT is not available or where the expertise for CRRT is not present, intermittent hemodialysis will probably be the best treatment of choice. And therefore, in that sense, they came to a very nice conclusion that suggested that whether be it intermittent hemodialysis, CVVH, CVVHD, or CVVHDF, it really has to be tailored to the patient's characteristics as well as available resources. The next question that I want to touch on is in a patient with sepsis and established AKI, when is the most appropriate timing to initiate renal replacement therapy? And this is one of the randomized control trials from the Netherlands group. What they did, they randomized about 106 critically ill patients into two main groups, one which is the early CVVH versus that of the late CVVH, where they define early CVVH as within 12 hours of meeting the inclusion criteria, and most of them had the dialysis started at about 6 to 7 hours, whereas the late CVVH group basically initiated dialysis based on the conventional, traditional criteria for renal replacement therapy, such as hyperkalemia, metabolic acidosis, or fluid overload. And on top of that, within the early group, they actually tried to see whether there was a dose effect and actually stratified that group into two groups, one to receive high volume CVVH and the other one receiving low volume. The primary outcome for this study was mortality at 28 days, as well as recovery of renal function. But however, because of the ambitious study design, the number of patients that they managed to recruit was actually quite small, and only with about 30-odd patients in each arm, and which is very likely to be underpowered to actually show a difference. And this was this was just as expected. The outcomes actually showed no significant difference in both of the primary endpoints for all three groups. And in addition, what happened was that all the oliguria AKI patients that were included, majority of them were actually post-cardiosurgical patients and not patients with sepsis. And we would know that, we would expect that post-cardiosurgical patients where the cause of the acute kidney injury tend to be circulatory-induced acute kidney injury and will probably be of a different pathophysiology compared to our septic patients. Be that as it may, there was actually quite a number of studies that actually showed that there might actually be a benefit of initiating renal replacement therapy early. And this is one of the meta-analysis that looked at all the studies. Now, and in this study, they concluded that there was actually some degree of benefits if we managed to initiate dialysis early. But I want to highlight that the majority of the of these studies are retrospective cohort studies, and there are very, very small numbers of randomized control trial. On top of that, a lot of the studies were actually done in the early 1960s to the 1970s, where the technology may not be as advanced as it is today, and which the results may not be applicable to the management of patients that we have of this date. And if we looked at the meta-analysis on the effects of timing of renal replacement therapy on the recovery of renal function, you will also notice that tends to be a trend towards favoring early renal replacement therapy. But look at this, there are actually only 2 randomized control trials, very, very few studies, the majority of them are still retrospective in nature. So there are limitations in the studies at that point in time in 2008 with regards to answering the question of what is the appropriate timing for renal replacement therapy. And this is due to the paucity of randomized control trials. There was significant publication bias, and that precludes a lot of definitive conclusions. There was different study population due to the changing demographics with different study areas. And of course, in many of the studies that was actually utilized in the meta-analysis, a lot of them had variable definitions on what constitute early renal replacement therapy. The cutoff for the blood levels of nitrogenous waste products, serum creatinine, potassium, as well as time hourly urine output measurements were very, very different. And if you look at this as an example, some study, if we use urea as a factor in determining what constitute early and late, you will notice that there is a significant overlap. Early, it ranges from 15 to 60, whereas late could be 27 to 82 with quite a bit of overlap. And that's also the case for using creatinine as a factor in determining what constitute then early timing. And with that in mind, there were 2 major trials that were published almost at the same time in 2016 that sought to answer this very important question. The first trial was the Alene randomized control trial. This is a German-driven trial. And what they did was they looked at the effect of early versus delayed initiation of renal replacement therapy on mortality in critically ill patients. And by this time in 2016, the KDIGO has already established some form of definition of, for acute kidney injury with the aim of trying to standardize the research language. And so what they did was they considered early as patients who were initiated on renal replacement therapy within 8 hours of achieving KDIGO stage 2 AKI, and considered late as within 12 hours of the development of KDIGO stage 3 AKI. And so with the primary endpoint of mortality 90 days after randomization, it would appear based on this study that the delayed renal replacement therapy has a much worse mortality data compared to patients who were actually initiated early. However, let's not forget that in this study, majority of the patients are again cardiosurgical patients. Most of them probably had circulatory induced ATN, and that might suggest that that there might be a difference in the outcomes of the patients that was randomized. The second study was actually a much bigger study, and this is basically looking at predominantly septic patients. And so this is the Akiki study. This is a multicenter randomized control trial. And what they did was they selected patients who already developed severe AKI with KDIGO stage 3 requiring mechanical ventilation, catecholamine infusions or both. And the early strategy, that was the group that was randomized into the early strategy had renal replacement therapy initiated immediately after randomization. That means the moment they reached stage 3, they started renal replacement therapy. And the group that got randomized to the late group had RRT initiated if at least one of the following was met, and these are the traditional indications for renal replacement therapy, and all of them received CVVHDF, so there was standardization in terms of what was the CRRT modality that was used. The primary outcome was overall survival at day 60. And in this study, it contrasted with the previous Alene study and showed that there was actually no difference in the terms of the mortality data between both the early as well as the delayed strategy group. But in fact, on top of that, the group that actually got randomized to the delayed strategy, diuresis, which is used as a marker for improved kidney function, tends to occur much later and much lesser in the group who received the delayed in the group in the group that received the early strategy. And in addition, the rate of catheter-related bloodstream infections were actually higher in the early strategy group. So they actually suggested that patients who had dialysis early actually may be more detrimental compared to the group where traditional indications for dialysis exist. And so Dr. Bagshaw and Dr. Wald, I think, who were both authors of the START AKI study, actually did a review of this topic in early this year in Kidney International, and they actually took all the randomized control trial to date and actually found there was actually not very much difference in terms of early versus delayed initiation of renal replacement therapy. And there are actually two studies that is in the horizon. One is the START AKI, which is going to translate from the original pilot study in 2015. And the other one is the IDEAL ICU trial. And we are waiting for the outcomes of these studies to give us a much better picture of what whether early initiation is beneficial. And based on existing evidence up to this point, Dr. Bagshaw and Dr. Wall suggested that perhaps for patients with acute kidney injury, the indications for dialysis should still take precedence in the clinical logic of the management of this kind of patients. So if there's presence of life-threatening complications of AKI, they would advocate starting renal replacement therapy. Otherwise, really, the other consideration for renal replacement therapy should take into account various of the patient factors, as well as the availability of the resources in the ICU. And next we come to what kind of dose should we be achieving in patients who had sepsis and established AKI? And this is the age-old question that we all been trying to answer. And this dose effect were actually brought into fashion by Dr. Claudio Ronco in the first publication in 2000 in The Lancet, where I'm sure most of us are actually familiar with this study. He actually, I will not go into the details, but suffice to say, he demonstrated that ultrafiltration based on an effluent of about 35 mL per hour per kilogram should be recommended for most of the patients who has acute kidney injury in the intensive care setting. Now, this is basically considered the gospel truth at that point in time, and this is what we learned when we were training as fellows. But however, in 2008 and 2009, there were three studies that were published that sort of threw away that sort of concept. And the first was a study published by Dr. Ashita Tawani from Alabama. And she basically looked at the standard versus high-dose CVVHDF for ICU-related AKI. And basically, they targeted a standard dose of 20 mL per kilo versus that of a high dose, which is 35 mL per kilogram. And half of the patient had septic shock as the cause of the AKI. But look at this. Despite the fact that they were targeting 20 and 35, the delivered dose and the achieved dosage was actually not close to what was targeted, where the standard only received at about 17 and a high dose at about 29 mL per kilogram per hour. And the study actually showed that the primary study outcome, which was mortality, found that there was actually no difference between the standard dose versus that of the high dose. And among the hospital survivors, 69% in the high dose arm recovered renal function compared to 80% in the standard dose. Again, no difference. And then the next study that was published in the same year was the VA-NIH Etienne Trial. And this is a much bigger study than Dr. Tawani's. It randomized about 1,124 patients into the intensive therapy arm or in the less intensive therapy arm. But unfortunately, the authors tried to complicate matters, and by including intermittent hemodialysis and SLAD as part of the intensive treatment arm on top of CVVHDF, which was given at 35 mL per kilogram per hour. And the less intensive treatment arm also had intermittent hemodialysis and SLED 3 times a week. So the frequency of the intermittent hemodialysis is what differentiated that between intensive versus less intensive, whereas the CVV-HDF, it was the effluent dose that actually differentiated the two arms. Sepsis contributed to, again, about half of the patient. There was actually a separation on the dosage in terms of the delivered CVV-HDF and that of the delivered HD. And we would know that it is very difficult to actually state that the KT over V from the intensive hemodialysis translate to the same kind of dose separation when we use CVV-HDF. And that is the main criticism of this study, that it's not really very much comparative. And this study, the study showed that there was actually no difference between the intensive therapy versus the less intensive therapy arm. In fact, if they stratify the various baseline characteristics, there was also no difference between the two arms. And in fact, if we looked at recovery of kidney function, there was actually no difference between the two randomized groups. And the third study was published in 2009, and that was from the Australia-New Zealand group. It's called the Renal Study, also a very big group, big study, 1,500 patients. They were actually randomized. Half of the patients had sepsis. They were in the ICU for about 48 to 54 hours before randomization. And about close to 90% of the time, the patient achieved the prescribed dose. And the high intensity was given at a dose of 40 mils per kilogram per hour, compared to the low intensity arm of 25 mils per kilogram per hour. This was done using CVV-HDF, and this was done using a post-dilution method of replacement fluid. And in this study, again, echoing the same results from the other two studies from Dr. Tawani and the Etienne trial, there was actually no difference in terms of mortality between those who received a high intensity versus the low intensity. And again, if we looked at the stratification of the baseline factors, there was no difference favoring either of the arm. And of course, with that, another meta-analysis, of course, came about. There were a total of about 8 randomized control trials looking at the dose of CRRT. And if you look at the randomized control trial, again, there is quite a bit of difference between the various groups. If you look at the dialysis modality, some use CVVH, some use CVV-HDF. So and of course, the Etienne trial included patients with intermittent hemodialysis and SLED. And again, so there was quite a bit of heterogeneity in terms of this meta-analysis of the studies that's involved. And again, so because of this great heterogeneity, it's also very difficult, as what Dr. Bouchard concluded in her paper, that this is actually very much difficult, poses quite a lot of difficulty in making very definitive conclusions on what is the appropriate dose. And there are quite a bit of hypotheses for why the negative studies happened, in contrast to Dr. Ronco's original paper in 2000, is that in both Dr. Tawani's as well as in the Etienne study, there was actually some delay in the initiation of renal replacement therapy of about 6 to 8 days, whereas in Dr. Ronco's study, most of the patients received renal replacement therapy after about 1 to 3 days. The delivered dose, of course, was much lower than prescribed in Dr. Tawani's study, as I highlighted earlier. And in Etienne study, dialysis is not necessarily equivalent between intermittent HD and CRRT. And again, in the Etienne study, what happened was that the site of delivery of replacement fluid was not standardized. So there were patients who actually received pre-dilution, and there were patients who received post-dilution. And majority of patients were enrolled after the initial dialysis. And with all that in mind, what we could only conclude was that we do not know whether a higher dose of CRRT is beneficial, but the KDIGO, based on all this available 7 to 8 randomized control trial, recommended delivering an effluent of at least about 20 to 25 mils per kilogram per hour. And really, the original advocate by Dr. Ronco to give a dose of 35 mils per kilogram per hour has not been given a very good grade in the KDIGO guidelines. And this is probably the current practice now. We aim for about 25 mils per kilogram per hour, and we actually don't move up to 35. And finally, I would just want to end off in the next 2 minutes, as in patients who have sepsis but no established AKI, is there any evidence in initiating preemptive CRRT? And that is because of the theoretical advantage of actually removing inflammatory mediators, but that doesn't seem to be the case in this paper that was published in 2002. They took patients with septic shock but no AKI and randomized them to receive 48 hours of CVVH 2 liters per hour with no hemofiltration, and there was actually no clinical benefits and no significant reduction in cytokines. But they did sort of made a caveat that perhaps a much higher dose may tend to show the effect, but with this dose, there was no difference in the cytokines. And in one of the few randomized control trial, very small numbers, 30-odd patients in a French unit, the French tends to do a lot of ICU trials. They actually did an early CVVH before the development of AKI, and they used a high-flux polysulfone filter. And again, there was no modification in the plasma levels of cytokines that could be detected. And the number and severity of organ failures were actually significantly higher in the hemofiltrate group, while time to death in both groups were not statistically significant. So to conclude, acute kidney injury is a common occurrence in patients with severe sepsis and septic shock, and is associated with significant morbidity and mortality. So the choice of renal replacement modality, be it intermittent hemodialysis or CRRT, should take into consideration the available resources, patient's conditions, and the physician's familiarity, and studies to date have been inconclusive. The timing of renal replacement therapy should be guided by clinical logic rather than numerical cutoffs, and it is widely accepted that a minimum dose of an effluent volume of 20 to 25 mL per kilogram per hour be delivered, while controversy still exists regarding the benefits of further increase in dose, and there is no evidence for the benefits of starting renal replacement therapy preemptively before the occurrence of AKI, and which could even have deleterious effects. And I thank you for your attention.
Thank you, Dr. Liew. I'd request the comments and questions for the next 4.5 minutes.
Can I start with the questions?
Sure.
If you sort of synthesize Akiki and Alene, when we synthesize both Akiki and Alene, is it possible that we are starting late? Because Alene says if you start at Akin stage 2, it is beneficial. But if you go by stage 3, maybe the sepsis conundrum has set into place.
Yeah, well, so the thing is that if we look at the KDIGO definition of AKI stage 2 and stage 3, stage 2 and stage 3 still do not have the traditional indications for renal replacement therapy. It's really based on serum, the urine output, creatinine, etc. So in that sense, it still sort of fulfills that part. When we talk about delayed initiation of dialysis, we tend to consider delayed as the point in time where indications of renal replacement therapy occurs. So now the question is, what is early? Early is before the traditional indications occurs, and now the difference between Alene and Akiki is that one tends to be much earlier, one tends to be a little bit later, but still forms that early replacement therapy. So, yeah.
Thank you for an excellent lecture, Professor Liew. I just wanted to ask you, in your hospital, who takes the decision of CRRT, the intensivist or the nephrologist?
Oh, so in my hospital, the nephrologists are quite powerful. So
I have one question. Is there any role of pulse high dose CRRT? Like you are giving a standard dose, intermittently you are using a high dose. In certain studies, they have shown mortality outcome is better if you use the intermittent high dose CRRT, like 4 to 6 hours of 5 liters, something like that.
So there's not much data on this, and there is a study that's ongoing. It's called the Ivore study. They're looking at 70 mils per kilogram per hour. The data for that study is going to come out much later. The problem I have with giving that pulse intermittent high dose is that, number one, it's really expensive. Number two, your ICU nurses are really going to hate you because they are literally going in every hour to change the bag. And so because of that high resource requirement, I don't tend to do it unless there's really strong data that's coming out. And we look forward to the Ivore study, which is supposed to be quite a big study that looks at a very they're looking at ultra high, between 40 and 70. So we'll wait for data coming out from there.
Okay.
Any questions from the audience?
No.
Now the question is, are we really using CRRT in the pathophysiology of sepsis or AKI in sepsis? Because just Dr. General Verma said, the pathophysiology is apoptosis and inflammation.
Yeah, so you see, I don't think we are using CRRT now in the way as the pathophysiology of cytokine release and removing inflammatory. Because if you look at the preemptive study, looking at some of the doses we're using, there's actually no evidence to suggest that based on the dose we're using, we are able to remove significant amount of cytokines. And in a patient who is septic, the cytokine release is continuous, and and I suspect that you need a really, really high dose. And that's why the Ivore study will be very useful to show that if we use a super ultra high dose, whether the pathophysiology and the theoretical advantage really translate to clinical practice. But based on the current dose we're using, even if we go up to 35, I doubt we are actually doing it because of the pathophysiology.
The other issue is we are chasing TNF, tumor necrosis, interleukin, but whereas now it is believed that angiopoietin, Adams tree, they don't come out through our filters.
Exactly, you're right.
That's all the time that we have, Madam Chairman. Thank you very much, Dr. Liew.